We're live, guys. I'm not
Okay.
sure about the
It's probably
audience.
gonna it's probably gonna take some time for some people to join.
Oh, yeah, okay, we did get one like here. So, I mean, it is a recording, so we can just start.
Awesome. Sounds
Yeah,
good.
yeah,
Let's do it.
yeah. Hey, everybody. Yeah, welcome to the first ever YouTube Live. Yeah, my name is Fat, and today we do have Neurosurgeon Dr. Z on today. And so, what I'm going to do is I'm going to explain for those who don't know what a neurosurgeon is. So, a neurosurgeon is a medical doctor who specializes in diagnosing and treating conditions that affect the brain, spinal cord, and nerves. And so, they can perform both surgical and non surgical procedures and treatments. So neurosurgeons, they're considered to be among the most difficult doctors to become because of the complexity of the nervous system as well as the risks of surgery. So without further ado, please welcome Dr. Z. He'll be talking about the brain.
Thank you so much for having me, man. This is a fantastic opportunity, and I really like what you're doing for your channel. So, I guess the important thing is to kind of, spread knowledge, spread awareness about strokes and how it impacts the brain. And there's a lot of misconceptions, I guess, related to stuff like this. And people sometimes think that if you get a stroke, then it's automatically a, life-ending sentence, but that's not necessarily the case. A lot of times, it can just be a life-changing type of event, but it doesn't necessarily need to lead to something as catastrophic as sometimes what people may assume. Now, in some circumstances, it can be extremely catastrophic, but nowadays we have several different interventions that we can provide to patients to kind of help with the presentation of stroke. So if somebody comes in and they have an occlusion of a blood vessel, I made a video talking about these blood vessels and stuff. If somebody comes in and they have an occlusion of any of these blood vessels, there are ways as physicians, as neurosurgeons, as neurologists, that we can treat these clots that are inside of the brain and inside the blood vessels. And so the two primary ways that we can do that is with medication that's designed to kind of disintegrate blood clots. It'll break up a blood clot, or we can actually go in there manually with special guide wires and special catheters and find the clot and suction it out ourselves. And Spirit Junkie looks like joined the live, so shout out to Spirit Junkie. Thanks for joining us.
Hey, nice. Hi, Spirit Junkie. Yeah.
Anyway, so yeah, there are many different advances that have happened in the past several years that have improved the outcomes dramatically for patients that have strokes. But I think it's important to underline and highlight the different types of strokes. You have usually two different types of strokes. There's an ischemic stroke, which means that you're going to have a blood clot inside of a blood vessel that prevents blood flow to get to a certain part of the brain. And you can also have something called a hemorrhagic stroke, where you have a brain bleed that can more or less compress some brain tissue and lead to poor outcomes that way. So those are the two different ones. They're very, very different in underlying etiology, but the concept is that for an ischemic stroke, you're going to have poor circulation, which means you're not getting oxygenated blood to that part of the brain, and then the critical thing to understand is that if brain, of course, doesn't get oxygenated blood, it's extremely susceptible to necrosis or cell death. And so if the cells start dying, that part of the brain will end up dying, and that's how people end up with deficits. So deficits would be depending on where in the brain the stroke actually occurs. And what a lot of times people don't really know is that the brain is very discrete, meaning that each area has a certain function to it. So, there's this strip over here that's responsible for motor planning. You have this strip over here that's responsible for the actual movement. That's called the motor cortex. And then you have the strip behind it called the sensory cortex, which is responsible for understanding and sensation and, processing different information from your senses. So it's very discrete. So every person will have these brain areas. So if you have stroke in the motor cortex, for example, that's how you get weakness on one side of the body. And depending on what blood vessel is obstructed, you can actually identify what symptoms that person is going to have. And as neurosurgeons and as doctors, this is unfortunately a dying art. But one of the things that my program during my residency really took
Mhm.
pride in is that we always had to identify the blood vessel that was occluded without looking at the imaging first, if possible. So we would always look at the patient. We would try to get an exam on the patient. It's not always possible because it's possible that they can come in a comatose state and you don't really have an exam. But if they're awake enough to kind of give you an exam, you can know just based on based on their symptoms what blood vessel is affected, because each occlusion of every blood vessel will give you a different constellation of symptomatology. So that's the concept here, and that's how medicine works. That's how neurosurgery works. That's what physicians do to be trained in this field. So we have many different tools in our arsenal to diagnose strokes, and different tools to treat them as well. And it's just growing over the past years.
Oh wow. You know,
Several
I
years.
I actually had a hemorrhagic stroke, just to let you
Oh,
know.
a hemorrhagic stroke.
Yeah.
I see. Okay, yeah. So hemorrhagic stroke is, for those that don't know, is a brain bleed. So I'm sorry that you had to go through that. Do you remember which side it was on? Which side of the
You
brain?
know what? It was my left side is affected, so it's on the right.
Gotcha. Yeah, so that makes sense. Yeah, the thing about hemorrhagic strokes is that there's a lot of different factors that will determine a person's prognosis in terms of the stroke, in terms of the bleed. So things like how big the brain bleed is, things like the patient's age, things like where it's actually located in the brain. All these things will determine if a person's going to have a decent prognosis or not. So believe it or not, the left side of the brain, if you were to get a bleed on the left side of the brain, majority of the of individuals are
Mhm.
left side dominant. Now, that's not to say that there's left brain and right brain individuals. That's not what I'm trying to say. But there are individuals that are left brain dominant versus right brain dominant, meaning if you impact their left side of their hemisphere, then they're going to end up having a worse prognosis or more symptoms associated with that, because a lot of times that's where your speech center is located, is on the left side. So things like Broca's area and Wernicke's area, those are the parts of the brain that allow you to understand and produce speech. And so if it's on the left side of the brain and somebody is very advanced in age, for example, sometimes those are
Mhm.
kind of key indicators that we say, maybe this isn't the best prognosis. But in your case, it sounds like all the stars aligned. You're a young individual. Sounds like everything is pretty healthy with you, and it was on the right side of the brain. So it sounds like your prognosis was good, and here you are.
Yeah, I feel like it's from all the things that I have been doing up until this point, and so yeah, it worked out okay. But I do feel that after the first or second year, we weren't sure what was going to happen. So I'm glad that I continued with it and stayed consistent. I
Yeah.
think those things are really good for my recovery.
Yeah, of course, absolutely. I can see that you're really invested in this type of thing. So kudos to you.
Yeah, thank you. Yeah, it's so awesome. Yeah. I wasn't sure exactly like the whole story with my stroke, but I do want to spend some time eventually to go into more detail. I just know that I had a hemorrhagic and it was to the cerebellum, which is like I think mainly coordination.
So the cerebellum, so you had something called the posterior fossa hemorrhage, and posterior fossa hemorrhage is uh, among the other hemorrhagic strokes, but especially posterior fossa hemorrhages can be especially deadly. And the reason for that is because when you have a brain bleed and you're talking about a compartment of the brain that is located right over here, so this is the posterior fossa. If you have a brain bleed in that area, you're going to have bleeding that is contained within a hard surface, and as the bleeding expands, the brain is going to get compressed because the brain is literally stuck between a rock and a hard place. So as
Uh,
the bleeding expands, that's the hard place, and then as the brain gets compressed against the rock, that's how you get brain damage. Now, the cerebellum is especially concerning because if you have bleeding to this area, then you can have injury to the structure that's underneath it over here, and this is called the brainstem. Now, the brainstem is responsible for all of your normal bodily functions, things like your breathing, controlling your heart rate, your gastric motility, and all of your regular bodily functions. And so that's why posterior fossa hemorrhages are especially dangerous. And I'm glad that you are okay, because it's not uncommon for people to get something in that part of the brain and it gets so big that it expands at such a rapid rate. It compresses the brain stem, and then sometimes a person will arrive to the hospital after just a few hours and they would be considered brain dead. So it depends on the severity of the bleed, but yeah, like posterior fossa hemorrhages are not benign bleeds.
Oh, that's so good to hear that. I mean, it's fascinating to hear that. I know that my brain was bleeding to a point where they had to do a second surgery, and they didn't think I was gonna make it. But I'm
Oh, you
glad.
had a second bleed.
Yeah, I had a yeah after the first surgery. Yeah, yeah, something like that. After the first
Wow.
surgery, yeah, they had to do a second one because it swelled up, and
Yeah.
it got pretty bad.
Yeah. Sounds like Spirit Junkie said that she's had a left-sided ischemic cerebellar stroke. So I'm glad that you're doing okay as well. And it affected your speech and gait and weakness. Yeah. So all these things can be affected because the brainstem and the spinal cord is basically a highway for information to go from the body to the brain and then from the brain down to the rest of the body. And so, if any part of the cerebellum is impacted, it can kind of block that highway. So, information going to the body and back from the body could be impacted. So, that is very likely that it's not surprising that you had those symptoms. Unfortunate that you had those symptoms, but not surprising. Now, in terms of doing surgery for strokes, hemorrhagic strokes and ischemic strokes could both sometimes benefit from surgery. So it sounds like you had a posterior fossa hemorrhage. You probably had something called a suboccipital craniectomy. Does that sound right, or do you have something else?
You
Or you're
know,
not sure?
I'm not sure. Yeah.
Yeah, so a suboccipital craniectomy is, when you have bleeding, the cerebellum is located in this part of the head, right over here. So if you have bleeding over here, then you're going to have something called a craniectomy done because, like I said, it's stuck between a rock and a hard place. So one of those things has to go. Either the rock or the hard place has to go. So you're going to remove the outer portion of the skull so that you can relieve some of the pressure, so that the bleeding has somewhere to go, and that way it won't compress on the brain because now it's no longer a closed container. Now you're opening up that part of the skull to create more of an open environment for the bleeding to be able to expand, and then that pressure won't all be on the cerebellum. So that's probably why they did that
Oh, you
surgery
know
for
what? When you say that,
you.
I'm not sure if I had. Is that where they remove part of your brain and they put it in another area or something like that?
No, sometimes they can remove a part of the brain, especially in the back. If you have really bad
Oh,
damage
okay.
to that
Or the
tissue,
skull. I'm sorry. Yeah.
then yes. But when you do it back here, you don't really keep that part of the brain. You usually just, or
Okay.
that part of the skull. You can usually get rid of it.
Okay. I think that's what they did then. You're
Yeah.
right.
You have a lot of tissue back there. That's why. A lot of times people say, "Oh my God, you're not going to put the bone back." There's a
Yeah.
lot of muscle that kind of covers that part of the brain and that part of the skull. So even though you remove a significant part of the skull, and then you have all these critical structures exposed, you have such a thick layer of soft tissue that a lot of times, removing this piece of the skull is not really as impactful as people think it is.
Oh, okay. Yeah,
Yeah.
because I do have like this lump and there's a big scar on the back of my head. I don't know
Yeah,
if you
that
guys
makes
can see
sense.
it. Yeah.
Yeah, well, I mean, that's a little bit different from what we do for an ischemic stroke. So sometimes a person comes in, let's say they had a stroke to the middle cerebral artery, the MCA, and then they have a stroke on this entire side of the brain. What can sometimes happen is we need to do something called a hemicraniectomy. So a hemicraniectomy is where we drill holes into the skull, and then we take a special drill, and then we cut out a big piece of the skull. Half of their skull would be taken off, and then that piece of the skull would then be implanted into the abdomen to kind of keep it for safekeeping. It's called
Oh,
marsupialization of the skull, or we can put it in a sterile bone bank. But a lot of
oh,
times we take off a big piece of the skull so that way the brain can swell, and then after the swelling period is done, we can usually put it back. But the swelling usually gets worst, in the first 24 to 72 hours is usually when it starts to peak. And then after that time frame, if the person is several days out and they haven't had any sort of neurological deficit from the swelling, then you can usually just watch them carefully, and then a lot of times they'll do okay. But there's a lot of different ways to manage somebody that might need a hemicraniectomy. A lot of times you can increase their salt, and by increasing their sodium rather, you can kind of help reduce the brain volume, and then it can help the brain shrink, and it'll allow for more space to be made in that area. You can also give something called mannitol, which is in fact, a diuretic that actually allows for excretion of fluid, and then that can sometimes help reduce the pressure inside of the head. But a lot of things are medical management, and then surgical intervention is usually the last option. And patients that do get a hemicraniectomy usually are in a situation where it's life and death, and that's pretty much the only option left, is that you have to do a hemicraniectomy. And those individuals that get a hemicraniectomy, depending on all the factors we talked about before,
Yeah.
can do well. And I've seen that before, where we take off half of the skull, the patient leaves the hospital 6 months later, they come back, it looks like they never had a stroke, and it's incredible. And then
Oh,
we come
wow.
back, we take them back to surgery, and then we put their skull back in place. In some circumstances, if the skull hasn't been preserved the way that we wanted to, we would need to put an artificial skull plate
Oh, you
back
can do it?
on.
Yeah.
Yeah, so it's like a 3D printed skull piece that we will take, and then we will take it and we'll put it back onto the actual defect. We'll send a scan, a CT scan, to a 3D company, 3D printing company. They will create a model of your skull and then devise a special plate that is custom made for your defect of your skull, and then they'll put it back on. And that's where we come in as surgeons. We'll put that plate back on, and we give you cosmetic results back, because otherwise you have a big gap there.
Oh, yeah. Wow, technology is so amazing, huh?
Yeah.
Yeah. Well, based off of your profession, I'm so curious about it. Could you take us in, like, give us an example of like your daily life,
Yeah.
maybe like one day or something?
Yeah, so as of right now, I'm a fellow training in spine surgery. So to do what I do, I first thing I have to do is I have to wake up, and I need to go to the gym in the morning, because if I don't go to the gym, then it's not good for me, and also not good for my coworkers, because I get a little irritable. So I have to go to the gym, and so I go to the gym, but that means I have to wake up really early, because we go see our patients at around 6:30 in the morning, sometimes 6 in the morning. So I have to wake up exceptionally early. So I usually wake up around 3:30 or 3 o'clock in the morning, and then I get ready to go to the gym at around 4 o'clock. I go to the gym, work out for an hour to an hour and a half, and then I'm back home by around 5:30. I shower. I leave the house at around 6 o'clock. Get to work at about 6:30. And then after 6:30, we go see all the patients that we operated on the day before, and then make sure that they're all recovering well. And then once everybody has recovered, or once we've seen all the patients, we've written all of our notes and everything, then we go to the operating room. And then the OR, the first case usually starts at around 7:30 in the morning. And then it depends on how many surgeries we have for that day. Sometimes we have one surgery, sometimes we have up to 4 or 5 surgeries. And then we do those. And then once the day is over, whether that's at 2 p.m. or 12 a.m. Then I end up going home, and once I go home, I try to get some sort of meal in me before I go to bed, and then I wake up and do it again the following day. And so Monday through Friday, that's usually what it is. Thankfully, weekends are not as busy. I am still on
Oh, yeah.
call, which means I have to be available 24/7. Like, I can't leave my house. I have to stay here because I could be called at any minute. So I can't really. I mean, I can leave my house, but I have to stay within the city. Like, I can't
Yeah.
I can't venture too far away, because if there's an emergency, I have to be able to run to the hospital within 20 to 30 minutes. And so
Wow.
I have to be very local. So for pretty much an entire year, I'm a prisoner to the city that I'm in, which is not a bad thing, because this is kind of an exceptional place to be right now. So I really like where I live.
Yeah.
So there's worse scenarios, but yeah, I think that's an important thing to kind of mention here, because a lot of times people that want to be physicians don't really understand the sacrifices that you have to make sometimes. Like, I can't go
Yeah.
see my parents whenever I want to go see them. I can't go visit my siblings whenever I want to go see them. A lot of times they have to come see me, but it's not
Oh,
ideal, because there's so many people that have to come see me. I can't go see them, and it can be challenging sometimes. But it's
yeah.
important for people to understand that there's a lot of sacrifices made in this field, and so you really have to fall in love with what you're doing. And I've been doing this for the past 8 years, and so it's it hasn't gotten any better. So I really just have to kind of be cognizant of the reason why I decided to do this in the first place, whenever I start to get a little down. And
Mm-hmm.
then once I start realizing the impact that I can kind of have on someone's life, um, the selflessness of doing that really makes things a lot better. And I'm not a hero, because everybody that does this is making the same sacrifices. I'm not special. I'm not different from anybody else. It's just people that are in medicine don't really have the platform that I do like I do in this situation, to kind of explain to everybody what's happening in the lives of medical providers. And so that's kind of a brief look into my life and a brief look into the day to day that I do. And it's very rewarding sometimes, but a lot of times can be very taxing.
Oh, big time. Yeah. And thank you so much for sharing that. And by the way, you are a hero to me.
Oh, that's nice of you to say. It's honestly everybody that's in the medical field. It's I'm not
Yeah.
special. There's nurses, there's OR staff, there's custodial staff. Anybody who works in a hospital, the way to keep the hospital going is through many different people coming together to be able to establish a certain outcome. And with those people, that's how you kind of get the results that you hope for patient care. And there's not one person that's
Yeah.
responsible for it.
Hmm.
It just so happens that surgeons are the ones doing the surgery, but then you also have the anesthesiologists who have to put you to sleep during the surgery and keep you alive during the surgery. You
Yeah.
also
There's
have the
so
scrub
many
tech.
things. Yeah.
Yeah, you also have the scrub tech who needs to give you the instruments whenever you need it. You have the circulating nurse in the operating room. You also have the floor nurse who's taking care of the person in between surgery. So everybody has their role. And so it's kind of you to say that, but I
Yeah.
would say everybody involved in healthcare has some role in being a quote unquote hero. But
I like that.
it's a team effort. There's not one person; it's everybody.
Hey, thank you. I like that. As far as for people who have traumatic brain injuries
Mhm.
or stroke, what would you let them know about the ability of the brain to recover?
Yeah, the brain is honestly one of the most remarkable organs that I would say that we are trying to still learn about. But there's a concept of neuroplasticity, which I'm sure you've heard about in the past. And
Mhm.
neuroplasticity just basically means that if one part of the brain is affected, then it doesn't mean that that part of the brain is going to recover. Because typically, if the damage is bad enough that the brain cells die, those brain cells are gone forever. You don't get them back. So, whenever you're born with the total amount of brain cells that you're ever going to have for the rest of your life. But if you have some sort of damage that happens to the brain where you lose a certain part of those brain cells and a certain part of the brain no longer works, then you're going to rely on the concept of neuroplasticity to try to recover from that part of the brain no longer functioning. So, as I said before, specific parts of the brain will do certain things. And so, if that part of the brain no longer works, it doesn't mean that you're never going to be able to do that thing again. Let's say you lose the ability to open and close your hand. Just because that part of the brain is no longer working doesn't mean you will never be able to open and close your hand ever again. It just means that there are other parts within that area that need to compensate for the lack of function of this area, which means these neurons that are around that damaged area have to start making new connections with each other to allow you to be able to open and close your hand. Will it be the same as what it was before the injury? Very unlikely. Is it possible to go back to what it was before the injury? It's possible, but it's still very unlikely. So that's the concept of neuroplasticity. That's how recovery works after a brain injury. Now, it's possible that if you have an ischemic stroke, for example, you don't get complete cell death. You just have a temporary period of anoxia, but then the cells can still recover. And then if those cells recover, then you can regain some of your functionality. So, for example, something called a transient ischemic attack, or a TIA, is an event where you have a blood clot that travels to a vessel. That part of the brain is no longer getting oxygen. And then if that part of the brain doesn't get oxygen, then it stops working. But then when the oxygen comes back, the cells are still alive and they can just keep functioning the way that they were before. So that's called a mini stroke, when these strokes kind of resolve on their own. And that's very different from something called an LVO, or a large vessel occlusion, which is when you have an occlusion to the middle cerebral artery or any of the other major arteries that feed a big portion of the brain. So like the posterior cerebral artery, the basilar artery, the vertebral artery, all these things are called large vessel occlusions. And so that's different from small vessel occlusion. And so if you have a huge stroke, a massive stroke, it's possible that your function would never come back. It is very, very possible. But with things like physical therapy, occupational therapy, we have a lot of different mechanisms nowadays and tools within our arsenal to allow people to regain some of their functionality back. And the advancements that we're making in those fields is pretty remarkable. Um, I need to educate myself more on Neuralink, but a lot of the promises that Neuralink makes, uh, I really hope they're accurate. I know that there's still trials right now, but if the claims made by Neuralink are accurate, then that's going to be a groundbreaking technology that's going to change the lives of anybody impacted, not just by strokes, but neurodegenerative diseases.
Yeah, I need to look into that too. So Spirit Chunky asks, when your appendix dies, you remove it. Keep why do we keep brain that doesn't function? Does the body partition it off? You know what? As far as my brain, they did remove parts of my brain. That's all I know.
Yeah.
But yeah.
Yeah. There's when we do surgery to remove the skull, for example, if we see that there's brain tissue that is obviously dead, we'll sometimes just go ahead and suction it out. It's so soft, it becomes so soft that you can just use a suction that we have during surgery to just suction it out. Normal brain tissue normally does not get suctioned out that easily, but it depends on how late, how chronic your stroke is. The brain tissue will change the consistency of itself, and then you can just sometimes just kind of remove it. But if there's no reason to, we usually don't do that because sometimes that can stir up bleeding. It can create more issues down the line. It'll just leave a big gap inside of the brain that's not necessary. So yeah, that's one thing that we can do sometimes is, if we are doing a decompression, is just remove the portion of the brain that is already dead. But it's not always the case.
Okay, great.
Yeah.
I did have another question from someone in the community, and they asked about apraxia. And the question was, um, do you believe there's something that will help it improve or go away?
So with apraxia, I think it's important for people to understand that, apraxia means that, okay, let's start from the top. So in order for you to move your hand, for example, you have to come up with the idea that I want to move my hand. That typically comes from this part of the brain called the parietal lobe. From the parietal lobe, you then have to tell, that's called the ideation. The ideation portion of movement is thinking about moving. Then you have to take it to the supplementary motor area and the premotor cortex to plan that part of the movement, that part of the action. So that part of the brain is connected to that part of the brain, and then those two parts will communicate. And then the ideational part will be sent to the premotor area, the supplementary motor area, and those two areas will then say, okay, now we have to come together to figure out how we can move that hand. That information will be sent to the motor cortex. The motor cortex will then generate the signals necessary to be able to travel down through the brainstem, go to the opposite side of the body, and then be able to work at the neuromuscular junction to allow you to open and close your hands. So there's a big series of steps that are necessary to be able to actually carry out a movement. And a lot of things can go wrong within each one of those steps. And so apraxia means that even though the person has function and has the ability to open and close their hands, they have the muscular strength to do it. They just don't have the planning skills, the planning capacity to be able to execute it. So, apraxia would be if the ideational part is not able to send the information to the planning part, and then the planning part cannot send the information to the motor part. So, that communication within the brain is what's impacted, and that's called apraxia. Now, and then again, there's different types of apraxia. There's something called constructional apraxia, where you can't do certain things physically, even though you know the concept. It's like, okay, I need to open this jar, but your body just cannot execute that task. You're aware that you want to open the jar, you just can't do it. And so that's kind of what apraxia is. And so by
Mm.
doing that, by the brain kind of undergoing these different symptoms and having these steps that can be impacted, that's how the final outcome can be impacted. Can there be improvement? The short answer is yes. That's with things like physical therapy and occupational therapy. But again, a lot of this stuff really does depend on the different factors within the brain, the parts of the brain that are affected, but also the extent of the damage. All that stuff really comes into play to determine how much of a recovery a person will have after a stroke.
Oh, I really appreciate that. Yeah, Dr. Z, I do respect your time. It's been about 29 minutes. I don't know if you had any, other last remarks or anything.
No, I just wanted to give a shout out to you. I mean, you're really doing an incredible thing here, and I really appreciate you taking me on your show. I'm really happy that people like you exist that can kind of spread the information and the knowledge necessary to, as your name suggests, give hope to stroke survivors. And I think that's a very, very important thing to have in medicine, because a lot of times we focus so much on the negativity associated with stroke, saying you're going to have paralysis on the left side of your body for the rest of your life, where in reality there are things that can be done to help mitigate those results. And yes, it is a catastrophic event, but it's important to focus on the things that can be done after a stroke happens. And I think, you're taking a lot of your time to educate a lot of people on this, so kudos to you. And it's especially important because you've already went through something like this. And obviously people like Spirit Junkie, they take a lot of um, they take a lot of their solace in coming to people like you and tuning in, because they can kind of cope with stuff like this. I don't know if, yeah, Spirit Junkie said she had a stroke, so, or he or she had a stroke. So this individual said that they suffered a stroke and all that stuff. They are coming to this type of platform to kind of learn more about it and see what they can do. So you're really creating that platform, and I really respect you for that. So thanks for taking the time to do it.
Hey, my pleasure. Thank you so much, Dr. Z, for your time too to educate us. I think it's a lot of things that a lot of you guys do, and especially you, and that you do that we don't even think about a lot of times. And so, I'm glad that you're sharing it with us and just taking that time out of your day to, help us out too. So I really appreciate that.
I'm happy to do it. Thanks for having me on your show.
All right, thank you so much. Yeah, I'll make sure
Absolutely.
to share it on all platforms, and so
Great.
everyone can get the knowledge. But
That
thank
sounds
you so much.
fantastic.
Yeah, you take
Thanks
care.
again.
Have a
Take
good
care.
day. Yeah,
Yeah. Bye bye.
bye.